Hey everyone, I decided to go casual because this is a coffee break talk. So I am one of the Rad Partners VP Clinical Operations, and I work for Matrix Teleradiology, and I've been using ADOC for a number of years now. Some people call it ADOC, some people call it AI doc. It aids the doc and it's AI for the doc, so I don't think it matters to anybody too much. But I thought I'd give some background about basically what conclusions we've had from using it. Everybody's pretty curious about AI in actual practice, and I don't think everybody's using it yet, so should be a good talk. Agenda will be who we are, case for AI in radiology, RP use case with AI, and why the time is now. My background, I always start every presentation I do with the first Google search, just to keep me humble. I like the radiologists are parasites one. I started my telerad portion of my career. I was an interventional radiologist to begin with, but then I joined Nighthawk, and I was the first US-based finals reader for Nighthawk in late 2007, 2008. Nighthawk was acquired by VRAD in 2011. I was a senior medical director there for 7 years, and joined RP and helped bring Matrix, the internal arm of teleradiology, to fruition there. And we started with less than a dozen rads in 2018, and now we're at over 180. And in our teleradiology practice, we do use ADOC, and we've been using it for over 2.5 years now. For a pretty long time to be using technology and make a lot of insights as to whether it can help or not. So there's two areas where you think about AI assistance. I'm going to start with talking about triage and the steps that go through triage. The first thing you think about with radiology patient workflow, the study is ordered and the images are acquired. So that involves, AI can be involved in clinical decision support. Then you acquire the images itself, and the quality of the images can be handled with AI and the reconstructions. AI flags the text to retake any poor quality images, etc. Then the study populates the work list, and AI flags the positive studies to the top. The images are read, and AI uses computer vision to actually identify abnormal pathology. The report is generated, and AI detects urgent finding, hemothorax, positive hemothorax. AI understands that that's a critical finding and lets the referring doc know. So just looking at that, 1, 2, 3, 4, 5-step process, AI can be involved in every single step. Massive number of use cases. Everybody in this room can think of 100. So just to start with AI as a prioritization tool, and I'll just tell you that initially I thought this is not useful for me because I'm a teleradiologist. Everything gets read in 30 minutes. Everything is stat. What is the point, right? Like, why do I care about triage? Well, I think everybody understands we're in a huge radiologist shortage, and sometimes you go beyond 30 minutes. And then there was this thing called stroke that kind of exploded in teleradiology over the last 5-6 years. And those turnaround times can be anywhere from 20, 15, 10 minutes, you name it. So if you have a positive perfusion study, for example, you know what? You really want that at the top of your list. And even if you have a positive head CT, in the era what time is brain, and there's so many things that can delay a study, least of all, which is, the current teleradiology system where different groups are covering or internal groups are covering. I don't really know anybody that's not way behind, maybe in the order of 2-3 hours. So you do need a prioritization tool. Patient is scanned, AI analyzes every exam. The study goes to the server, the AI server. I'm going to generalize, right? We don't need to talk about ADOC necessarily, but an AI server. and then it prioritizes the case. Very simple. So what is the expectation? One, that it will prioritize positive findings and reduce, time that the patient is waiting. Two, it is always on. It is never going to the bathroom. It is never going for a break. It is always monitoring the list. Anytime a study comes on the list, it's monitoring. And then three, the expectation is it's going to improve outcomes. It's going to be something to work with. It's not going to slow the radiologist down. And then fourth, I think the expectation from AI is that it is FDA cleared. The FDA process initially, when AI was coming through, everyone was worried that the FDA would be a massive roadblock for AI and it would take 14 years to get any AI algorithm approved. They have proved not to have been that way. They've been very, very good about approving new algorithms, not putting it through the lengthier process for devices, et cetera, that would take years. And as a result, we have FDA approved algorithms. So here's a very, very self-explanatory, slide. Basically, in teleradiology, for example, where we're reading the order that the study is done, right? All of these head CTs, the one, that's on the list at 10, at 10:10, 10:20, 10:30, they're all equally stat. But the one at 10:40 needs to be read first. There's just no question about it. So here's what it does. It's going to take patient E, and the radiologist is going to read that first. Specifically with ADOC, we've had some really pretty amazing feedback. Positive CT pulmonary angiogram within 45 minutes saved her life. Really good pickup, subtle, well done. Thanks for the heads up, missed it on that incidental PE. Speaking of which, I actually will tell you guys that when I first started to use ADOC, I was kind of annoyed because I was like, this thing is gonna make my time longer. It's gonna slow me down. There's gonna be false positives, false negatives, and I don't need an AI algorithm to tell me about PE. I can find every PE on my own. I'm a former interventionalist. I use a standard search pattern. I look at the branches. In fact, I think I said to Nina Kotler, who's the ACMO for AI at Radparts, I think I said to her, I never miss PE. And so that was a fateful, very, 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 very stupid thing to say because, of course, just a few weeks later, I got a notification from my widget that I had called it a study normal and there was a segmental PE, not subsegmental PE, a segmental PE. And so what I realized more and more is that any radiologist can miss anything, right? Like, we've been at this long enough to know that. And so having a second set of eyes when we're trying to get through 100, 120, 130, 140, 150 cases in a shift is incredibly useful. We just never worked at these speeds before. And it's really helpful. So one thing, let's not dwell on very scientific numbers or anything, but if you look at specificity and sensitivity, you want your AI tool to be above 90% for both. It gives some room for artifact or some sort of false positive or false negative that is not able to be detected by a computer. It needs a radiologist's eyes to understand why. For example, misregistration from a patient's arm overlying the soft tissues can cause a vessel to disappear, right? I will tell you also that 2.5 years later, using ADOC, it never misses. It understands all those artifacts now because it's a true AI algorithm. It's learned from all those errors, and it has just thousands and millions of cases in its database now. So enhanced detection is a pretty important thing because that means that the radiologist didn't catch it, but AI caught it. And efficiency gains. So I'm a faster reader because of AI. What does that mean? So that means when there's COVID, pneumonia, and there's infiltrates at both lung bases, and there's motion, and the patient is 400 pounds, and the patient's arms are at their side, that those vessels are going to be really hard to read. So how do we as radiologists handle it? Well, I handle it by being meticulous, right? I'm going to look, I'm going to scroll once, I'm going to scroll twice, I'm going to scroll 3 times, I'm going to scroll 4 or 5 times. And most of the time, the report takes most of the time in our time as a radiologist in reading a case, making the report. It's not looking at the images. But I'll tell you that when you don't have to scroll that second, third, fourth, fifth time, you don't have to go through the lung bases real carefully, because I don't do that anymore. Honestly, if I look at my ADOC widget, it tells me the study has no pulmonary embolus. It's done that second, third, fourth, fifth time look for me. And I'm so confident in it that it has made me a faster radiologist. Now take the same thing and apply it to head CT. Head CT, everybody here in the room can detect a head bleed on their own. They don't need AI. But now, the patient is a trauma patient, elderly, and they're scanned. You've seen the scan sideways in the scanner, and you're like looking for blood. You're going to look, and there's motion, you're going to look 4 or 5 times. You're going to make sure there's no head bleed because the scan is grainy and it's just not a great scan. So that's where it really saves time. ADOC says it's negative. I don't need to look in the, in the peduncles or all the hidden spots, the middle cranial fossa, et cetera, where hemorrhage lies. I've truncated my typical search pattern. So let's look at this case. This is a real case. The first study was called negative. The blood is hugging the calvarium there. Of course, the arrows show it to us, and that's why we see it. It was nearly invisible. I remember seeing this case the first time. And this is real, just 36 hours later, it is a big bleed that needed decompression. Clearly a life-saving event right there. And I remember the radiologist that this case was, he is like converted to AI completely because he's like, this is real, this is a real patient, would have missed it, no question about it. The AI saved the patient's life because this bleed got much bigger. That patient was discharged and brought back actually for the repeat head CT. So here's one of those hidden places, anterior to the temporal lobe. We're busy, we get distracted, we get interrupted constantly. We have 19 things going on and we're reading fast. So, here's a very nice case. Hard to see, maybe, but that's a PE. That's a real subsegmental PE. What's the value of it? We don't know, right? Like, we don't know if that actually has a clinical, importance or not. Does the patient really need to be anticoagulated for it not? No, maybe not. We have some evidence of that. But our job is not that. Our job is to say, there's a pulmonary embolus here, and so it detects it. Here's some data. Intracranial hemorrhage at Cedars-Sinai. So this is generalized data, which is very important when you're looking at AI. You don't want to look at multi-center institutions. In teleradiology, it's a little easier because we are automatically multi-center, right? So if it's working for a big teleradiology practice, it tends to be working very well. And I'd say, at least in my experience, 90% of AI is not generalizable. It has beautiful results at one single center institution, but not at many. So number of percent positive findings caught only by AI. That means that the RAD did not see it and had to be notified that, hey, your report was negative, but you need to change it because we think it's real. And the RAD looks at the case and then says, yes, that's real. So in the case of, I just wanted to flag the 45% of incidental PE. So that's a study that's not done to detect PE, but our AI algorithm can actually find PE because most of the time they time it for the pulmonary arteries. And it's 45% because in half of those cases or so, there was a real PE and the radiologist called it negative. So it's a high number, out of 25 cases that were called negative on incidental PE. C-spine fracture, 11%. I mean, I think, I'm just old enough to remember when they were doing plain films to clear C-spines, and just incredible number of misses as CT, got more and more used. We're going to see the same thing with AI algorithms, is that, that's a significant percentage that we tend to miss. Just because they're very small sometimes and very isolated. You might only see it on the sagittal. It might be right next to the facet, et cetera, et cetera. So what's the bottom line? Just three things to think about is that I think the combination of a radiologist plus AI is better than either one alone. And secondly, the technology is mature at this point. It's working, and the key thing about AI is AI learns, so it gets better. So it's pretty impressive stuff. And then we, as radiologists, should help create, improve the technology. I think everyone at ADOC would admit that our practice helped them create a better product. We should utilize this product because nobody else knows it better than us. It should not be handled by administrators or non-radiologists. It should be us. Thank you very much.